afternoon and welcome. I'm Robin Grant, Director of Public Policy and Advocacy for the National Consumer Voice for Quality Long-Term Care. And I want to welcome you all to today's webinar entitled A Deeper Dive into the Revised Federal Nursing Home Regulations, Taking Another Look at Key Sections. This is the fourth in our Deeper Dive series that's designed to give you all a more in-depth understanding of the revised federal nursing home regulations. I think you could call this an even deeper dive because in this webinar we're focusing in on four key parts of the regulations that we've already covered in our previous webinars, but where webinar participants had a lot of questions. So we wanted to go back and cover those sections and dig into some of those questions that were posed but not answered. Next slide, please. So I want to just tell you just very briefly what we have planned. We'll start with just a brief update on the regulations since there have been some developments since our last webinar. I will provide that update along with Lori Smentanka, who's the Executive Director of Consumer Voice, and we'll then focus on four topics that we have covered in the past: Rehabilitation Services, Visitation, Transfer-Discharge, and Return to the Facility. We'll include answers to some of the questions we received on those issues in our discussion and in most cases give you a little bit of a refresher on the regulation. So in addition to Lori and me, our speakers will be Eric Carlson, who's Directing Attorney with Justice and Aging, and Toby Edelman, Senior Policy Attorney with the Center for Medicare Advocacy. After we've spoken about those regulatory issues, Eric is going to provide some information about the Senate healthcare legislation, and then we'll open up the call for your questions. Before we start, let me cover just a few logistical details. Right now, everyone's lines are muted so that you can hear the presentation without background noise. As I said, we're going to answer questions at the end, but if during the presentations you do have a question, you can go ahead if you want and type it into your question box, which usually is on the right-hand side of your screen. And as you may have heard, this webinar is being recorded and we'll make both the recording and the PowerPoint slides available following the webinar. So not to worry, we know that most people really want copies of the slides, so they will be coming your way. Okay, with that, let's go ahead and get started because we have a lot to cover. Next slide, please. So we want to give you updates on three different issues. So the first update relates to discharge notices going to ombudsman. Many of you'll remember that the revised regulations state that a notice of transfer discharge must be sent to a representative of the Office of the State Long-Term Care Ombudsman. So there has been a great deal of confusion about exactly what notices should be sent. And many ombudsman programs reported being flooded with every single type of notice imaginable, and one program actually even reported getting notices when residents died and the bodies were transferred to the funeral home. So lots of confusion. So CMS drafted guidance on this issue, and it was released in a survey and certification memo on May 12th of this year. And in the guidance, CMS makes a distinction between facility-initiated and resident-initiated discharges, and also makes some distinctions between transfers and discharges. Now, Eric is going to talk about this guidance when he talks about transfer discharges, so I'm not going to discuss this further right now, other than to say that the guidance really did make it clear when copies of the notices have to be sent to residents and representatives, so that's certainly a very good thing. There's a second update regarding the regulation about notice to the ombudsman, and I'm going to talk about that when we get to the third point, CMS's request for feedback. So right now I'm going to turn things over to Lori, who's going to give you a brief update about what's happening in terms of the rule on arbitration. Lori.
Great. Thanks, Robin. Hi, everyone. So as you recall, in the final rules, CMS included a provision that would have prevented facilities from entering into pre-dispute arbitration agreements and also would have prevented them being required as conditions of admission for residents that were entering a nursing home. But earlier this month, CMS issued proposed rules to revise that segment of the final new nursing home rules. And in the proposed rules, CMS has removed those requirements that would prevent facilities from entering into pre-dispute arbitration agreements, and it also removes that provision that would ban them from requiring them as a condition of admission. Instead, not only do they allow them, but they require that specific things must be put into place if they were going to be required, such as the agreement would need to be explained to the resident and his or her representative in a manner that they understand, that the resident would have to acknowledge that they understand the agreement, and that the agreement not prohibit or discourage the resident or anyone else from communicating with federal, state, or local officials, such as a surveyor or an ombudsman, with respect to that agreement. CMS did keep in the proposed rules language that if a dispute is settled through arbitration, a copy of the signed agreement for binding arbitration, as well as the arbiter's final decision, would have to be kept by the facility for 5 years and be available for inspection upon request by CMS or its designee. Additionally, CMS would require that the agreement be in plain language, and if it is a condition of admission, which is a new thing, that now CMS would specifically allow it to be a condition of admission, that it be in plain writing in the admission contract. And then lastly, CMS is proposing that facilities be required to post a notice describing its policy on the use of agreements for binding arbitration in an area that's visible to residents and visitors. They've taken out language that they put into the final rule that we're currently working under that would require that any post-dispute binding arbitration agreement be entered into voluntarily by the resident, that a neutral arbitrator be mutually agreed upon, and that the venue for arbitration be convenient to both parties. Those provisions have been removed under the proposed rules. So this is a complete change of course by CMS on this particular issue. As I mentioned, these are proposed rules that are out. CMS is accepting comments on them for a 60-day period, which means that the comments are due on August 7th of 2017. And if you would like to see a copy of the proposed rules or need more information about it, there's more information on the Consumer Voices website, and you can access it there. So Robin, I'll turn it back over to you.
Great, thanks, Lori. So the third update we wanted to share with you is that on May 4th of this year, CMS published in the Federal Register a request for what it called stakeholder feedback on certain provisions in 3 areas of the regulations. CMS said that it was considering these particular provisions for, and I'm quoting, modification or removal in an effort to reduce the burden and financial impact imposed on long-term care facilities. The provisions that they're asking about pertain to the following 3 areas: the grievance process, quality assurance and performance improvement, and admission, transfer, and discharge. So I just want to drill down a wee little bit into the discharge notices to ombudsmen. In this particular area, CMS was asking for feedback related to 3 questions. One is sending the discharge notice to the long-term care ombudsman achieving intended objectives to reduce inappropriate involuntary discharges. Second, does the long-term care ombudsman program have the capacity to receive and review and handle these notices? And to what extent will ombudsmen use the information in notices that they receive? So in addition to seeking input on grievance processes, the quality assurance and performance improvement process and notices to ombudsmen, CMS just opens the door completely and asks for feedback about any additional areas of provider of burden reduction and cost savings in facilities. And we're certainly interpreting this as asking providers basically to identify all the regs that they would like made more flexible or even eliminated. So comments were due this past Monday, and now we'll just have to wait and see what CMS does with them. So to say the least, there is a lot going on, and all of us will work hard to keep you as up to date as we possibly can. So we're now going to turn to our deeper dive into 4 key areas, but first, just a quick reminder, as you can see on the screen, the regulations were implemented in 3 phases. I mean, they came out to begin with, they were published in October of 2016, but they're being phased in over time. As you can see, most regulations went into effect last November, and that was phase 1. Phase 2 goes into effect November 28th of this year, and then there's a 2-year gap before phase 3 is implemented on November 28th of 2019. So I believe, with the exception of one provision about documentation under transfer-discharge, all the regulations that we're going to be discussing today are already in effect. Okay, let's begin our dive, and we're going to start with Toby, who will discuss Rehabilitation Services, and I hope you can pronounce it better than I did, Toby. So I'm turning it over to you.
Not sure I can. Thank you, Robin. CMS hasn't made any changes in the rehabilitation and therapy regulation since the last time we talked about these issues. And even then, even the revised requirements are not particularly different from what we've had in place for a long time, except for the addition of respiratory therapy, which we discussed quite a bit last time. But I wanted to answer some of the really excellent questions that were submitted, just a handful of them, although there were many more. The only change I wanted to bring to everybody's attention is an advance notice of proposed rulemaking that was also published May 4th on a totally new reimbursement system for Medicare, replacing resource utilization groups with something CMS is calling resident classification system. We did get an extension in the public comment period because the industry asked for it. So there was a 60-day extension until the end of August. There's an alert on our website, the Center for Medicare Advocacy, on May 17th, and we'd be happy to send the link, which talks about the new system in detail. Let me just say briefly that what it does essentially is gut therapy entirely, saying it will pay more money for facilities that provide less therapy to their residents. So a facility that provides one type of therapy, not 3, would get a higher reimbursement than a facility that provided all 3 kinds of therapy. The shorter the duration of the Medicare Part A stay, the higher the reimbursement. So it's a pretty disastrous system. But turning to the questions that were asked last time, which were really very, very good. The first one is, to what extent can a facility be encouraged or required to resume physical therapy or occupational therapy for a 52-year-old quadriplegic who became eligible for Medicare in January 2017, and is now only receiving restorative therapy, range of motion, and is regressing. This is really a very serious and common problem. The term restorative therapy is SNF's term for non-Medicare covered therapy. And it basically means that there'll be an aide who will do range of motion. This is not covered. Why they call it restorative, I don't know, but it seems to be a term that has swept the industry across the country. That's what they mean when it's not going to be paid by Medicare. So the answer to the question, what do you do for this person? Well, if the person is in a Part A stay, and if the skilled nursing facility resumes therapy 5 days a week within 30 days of stopping it, then the resident could pick up the benefit period where it stopped. So, for example, if the person had gotten 30 days of Part A coverage and the SNF stopped therapy for 2 weeks and then restarted it, the person could restart that Part A stay, and that would be day 31. There'd still be a 2-week gap, but the person could start the Medicare Part A benefit period. If the resident can't resume a Part A stay, if it's past the 30 days, or if the resident has already used all 100 days in the benefit period, the resident could get therapy under Medicare Part B. That's considered outpatient, even though the person is living in the facility. It's the same standard under the JIMO litigation. If the resident needs therapy and the therapy must be performed by a professional so that it can be performed safely and effectively, then Medicare covers the services, whether the resident needs therapy to improve or to maintain function or prevent or slow the resident's decline or deterioration. If the person is regressing, as this question asked, then it's important to ask for a new evaluation. We don't want the regression to happen, but facilities do a lot of self-help and stop therapy when they decide Medicare won't pay. So ask for a new evaluation. If there's an agreement that the person has regressed, then the person could get Medicare coverage under either Part A or Part B as appropriate. The next question was, if somebody is in a facility under a Part A stay and plateaus but requires the skills of a therapist to reduce the decline in function, can the person continue and exhaust their 100 days of the Part A benefit? The answer is yes. Person can continue that 100 days, shifting from plateau, from an improvement goal to a maintenance goal, but there needs to be a new care plan if maintenance becomes the new goal. Residents don't automatically move from improvement to maintenance. It needs to be a new care plan that establishes that very clearly. Question, can you define therapy professional? The answer is a licensed therapist. The therapy aides don't count for this purpose. The person needs to be a professional. Next question is whether, if a resident has been in and out of a nursing home for a hospital visit, do the therapy days start over again? If it is a stroke patient, does maintenance continue up to 100 days under JIMO? So the answer is the therapy doesn't start over again just because somebody is hospitalized. The only way to get a new benefit period is that there needs to be a 60-day gap when the person is not in the hospital and is not getting skilled care in a SNF. Then the person needs to be rehospitalized for at least 3 consecutive days as an inpatient, and all of those requirements. That's how you start a new benefit period under Medicare Part A. I think that's why we call it benefit period and not spell of illness, because spell of illness implies that you have a new medical problem. I recently had a call like that. Somebody had, first he had a problem with pacemaker, then he broke his leg. He said, do I start a new benefit period? I said, no, there hasn't been a 60-day gap. So benefit periods are hard. I think maybe I should just answer one more question or bring up one more question. If there's time later, we could do more, and we'd be happy to get more. But the question is, what do we do to compel a facility to provide more than restorative therapy to a resident whose payment source is Medicaid? Especially with TBI, improvement can be slow, but can still happen. I guess to me, the question is, what's in the care plan for a Medicaid person? And I think this also depends upon how Medicaid pays facilities. Do they pay more above the daily rate if the resident needs therapy? Or does the Medicaid rate assume that therapy will be provided for some people within the Medicaid rate? If the resident is dually eligible for Medicare and Medicaid, and most are, of course, the question is whether the state will pay the Part B premium or the copayment for the therapy for the resident. So I think we want to insist, and it was important to us as we discussed before, to insist that Medicaid people get the therapy they need as well. The services are supposed to be identical regardless of source of payment, and I think we should be pushing and encouraging facilities to provide the appropriate therapy to people, either to improve or to keep them functioning at the highest level possible. Just one quick comment. I've been speaking to a home care agency about the benefit of maintenance therapy for their home care patients, and the person told me in the 3-year period that they have actually been providing maintenance home care to people, they've seen their rate of hospitalization decline from 30% to 14.2%, more than half. And I think we need to be able to show the Medicare program and the powers that be that providing maintenance therapy to people in nursing homes is also going to keep them healthier and safer and out of the hospital, which is their primary concern. So I think I should turn it back to the program and get on with the other issues here. Thank you.
Thank you, Toby. Next, Lori's going to talk with us about visitation. Lori.
Great. Thanks, Robin. So there were a number of questions about visitation after we went over this material the last time, but most of them actually revolved around whether there were others who were able to essentially decide who gets to visit with the resident or not. Does a person who has power of attorney or a guardian or a family member get to decide whether or not a resident has certain visitors? And when you go back and look at the regulation, it's very clear that residents get to choose their own visitors, anyone with whom they choose to visit. CMS really talks about this right as an extension of their right to self-determination, and that residents can give consent for visits with persons of their choosing and withdraw consent at any time. Essentially, CMS has said that as long as a visit is not imposing on the rights of other residents, the facility cannot place limits on who the resident receives as a visitor, and that the visits can occur when the resident chooses. So if it's most convenient for them to visit early in the morning or late at night or at any point throughout the day, as long as it's convenient for the resident, accommodations can be made in order to provide for that visit to happen. CMS does, in other sections of the preamble and discussion, talk about the relationship between a resident and a representative. And they reinforce that a representative can only exercise the rights given to them under their agreement, such as a person who has power of attorney, or a court order, such as a guardian, but that even residents that have an agent under power of attorney or a guardian, that the resident's wishes and preferences should continue to be considered by any representative in decision making. And we see that as best practice and as standards that are promoted by organizations like the National Guardianship Association and other types of organizations that have looked at and thought about and written about this issue. We know also that even a resident with limited capacity can express a preference to see someone or express their wishes even if they're not able to verbally communicate. There are other cues that need to be taken into account or other methods of communication that the resident can use to really express their preference. So in determining the wishes of a resident to see a particular visitor, they really need to be looking at what are the resident's wishes and preferences. And if they're not able to talk about, to say, currently whether or not they want to see that person, what is their past history in terms of their relationship with that person and whether or not they had an ongoing visitation schedule with them or a relationship with them that would lead you to believe that they would want to see that person. Essentially, it's looking at taking into account the accommodation of the resident's needs and preferences. Next slide, please. When you look at the regulations, it talks about the right to immediate access to the resident by actually most visitors. Most of visitors do have should have immediate access to the resident. That includes representatives of the secretary or the state, and that would include surveyors, for example, or a long-term care ombudsman, the resident's individual physician, and newly added in these regulations was the resident's representative, that person should also have immediate access to the resident. Other family members and relatives also are to be provided immediate access to the resident, but those are subject to the resident's right to deny or withdraw consent. So a resident at all times has the right to withdraw consent to visitors if they choose not to see them, even if they have wanted to see them in the past. So again, it's going back to what are the resident's wishes and preferences at that time. Next slide, please. In the sections where CMS does talk about restrictions on visitation, they carefully looked at those categories of visitors where restriction might be permitted by statute. And they went back to the provisions of the nursing home reform law and discussed that in the preamble, which is the sections before the regulations, which talk about CMS's rationale for why they made the decisions that they did. And when looking back at the nursing home reform law, other visitors is others visiting with the consent of the resident is one category, and those folks should have immediate access to the resident, but they may be subject to reasonable clinical and safety restrictions. And then there's another category of visitors, any entity or individual that provides health, social, legal, or other services, and they are to be provided reasonable access to the resident. But all others, as I mentioned, are to be provided immediate access. So next slide, please. So when looking at what those restrictions are, in these regulations, CMS has said that any restrictions need to be reasonable and based on clinical and safety provisions or safety concerns. They talk about the need for a facility to have written policies and procedures for visitation that include these restrictions, when these limitations may apply, the reasons for them, and they must also inform residents when a limitation on visitation would occur and to whom those restrictions would apply. So facilities need to think through what their policies are around this, and then residents need to be informed about that before they go into effect. Next slide, please. In thinking through what do clinical and safety restrictions mean, CMS does provide a little bit more information about that again in the preamble. They give some examples of what that might be. So certain restrictions, for example, that would protect the security of residents, like keeping the facility doors locked at night, denying access or providing limited or supervised access to visitors if they have been found to have been abusive or exploiting a resident. Those are examples of safety restrictions that can be imposed. Clinical restrictions refer to the need to prevent, for example, communicable diseases. CMS has said that those could be taken into account. However, if restrictions are being put into place, there need to be systems in place by the facility that would allow approved visitors that have immediate access to the residents, as the regulations talk about. So there needs to be some thinking through how to assure that residents still get to meet with their visitors, even if they may be subject to restrictions based on being part of that other category. So really it's looking at evaluating each situation based on its own set of facts and circumstances, and looking at what options might be available if there is, for example, a challenging visitation situation, looking at what actions might be required or what solutions might be put into place for dealing with someone who might be a challenging visitor, or if there need to be other health restrictions that might be put into place. So might there be a private room that's available for a resident to visit with a family member if there are restrictions in place based on a flu outbreak or epidemic, for example, or might the facility ask visitors to wear masks? So looking at each different situation and looking at how to make it person-centered and how to assure that residents have the ability to visit with their friends and family members, even if they are challenging situations, is an important thing that the facility needs to apply, because as we know, the regulations are very resident-focused, and they actually provide for an absolute right for a resident to visit with certain people, particularly with their family members. So with that, I'm going to stop at this point, and we'll turn it back over to you, Robin.
Thanks, Lori. Our next deep dive is into the area of transfer-discharge, and I'm going to turn the program over to Eric.
Thanks, Robin. Robin mentioned earlier this recent CMS guidance, the letter that's survey and certification letter that's cited in the middle of the screen. As Robin mentioned, the big distinction as to whether a notice should be issued is whether the transfer discharge is facility initiated or not. So if you go back and look at the statute or at the regulation, maybe surprisingly, there's no mention of whether something is voluntary or involuntary. I know a lot of us in talking about this always refer to involuntary transfer and discharge, but actually the language is broader than that. The facility is obligated to give notices whenever there's a transfer or discharge. So the question arises, what do people want to leave? And that's the distinction that the guidance tries to make. The basic rule on all of this is you generally get 30 days notice. In some situations, less notice is allowed, as long as and the notice has to be given as soon as is practicable. So now that the notices are shared also with the Ombudsman program, this issue has gotten more attention, although it was certainly very important even before, when the notice went, quote unquote, only to the resident and the resident's representative. I would suggest, I think this is consistent with what CMS is saying, is that facility initiated should be interpreted broadly, or alternatively, resident initiated should be interpreted narrowly. And this is because of the realities of the nursing facility situation. We don't want situations where facilities suggest or cajole, in one way or another, pressure people out of the facilities and then say, well, we didn't have to give a notice. The resident left on his or her own volition. When not really. That's not how it played out. The facility really did the initiation here. And so this guidance from CMS is quoted on this slide, I would think is consistent with that the transfer discharge can be considered resident initiated only when the resident, or if appropriate, the resident's representative, has provided verbal or written notice of intent. Gone to the facility and said, I want to leave. And in those circumstances, that it's then appropriate, as you can understand, that the facility not issue a written notice of transfer discharge listing appeals rights. The goes on to say that appropriately that the resident's expression of a general desire or goal to return home, that is the resident saying, I wish I could leave this place. That's not good enough. Just, if the facility then forces the person out, there has to be notice, or, and this one's really obvious, if someone with dementia just wanders out of the facility, that can't be considered somebody's decision to leave. That's not resident initiated for these notice purposes. So again, the danger is we don't want to allow the situation where a facility, just because of the power dynamics of the situation ends up forcing the person out. And in practice, that most often comes to a head right now when somebody's Medicare reimbursement is ending after the person has been in the nursing facility for a week, 2 weeks, 20 days maybe, and the facility then says that Medicare reimbursement is ending, and then may simultaneously say or suggest that maybe the person should just go on his or her own way and move elsewhere. As folks probably understand, there's financial motivation for a facility to do that in situations like that because the Medicare reimbursement is the highest rate of reimbursement that the facility gets, but that's very inappropriate from the resident's point of view. You don't want a situation where residents go to the facility, get some care under Medicare reimbursement, and are just pushed, forced, cajoled out the door to be replaced with somebody else who's eligible for Medicare reimbursement, and then have the cycle start over again. I think in that situation, facilities and advocates need to be really scrupulous about this, that facilities are obligated to give Medicare notices about the Medicare coverage issues. If the Medicare is handled through a managed care organization, if it's Medicare Advantage, there's similar notice requirements, but that should cover only the reimbursement. Who's going to pay for your stay? And that should be entirely separate from whether you intend to live here or not, because obviously if one reimbursement ends, it's possible for the facility, for the resident rather to stay under another kind of reimbursement, Medicaid, or paying out of pocket. And so what should be happening in this situation, there should be this notification regarding payment, and then if the facility independently is suggesting that the resident has to leave the facility, which they shouldn't be under those circumstances because the resident has a right to stay under some other kind of reimbursement, they have to be given a notice alleging whatever their purported reasons are for forcing the person out and listing the appeal rights. So two things. The facility should be very clear that Medicare and Medicare Advantage is only about payment. That's separate from the person's right to stay in the facility. In most cases, then the person should absolutely have the right to stay under a different form of reimbursement. And if the facility is going to suggest anything different about the person going elsewhere, there needs to be a transfer discharge notice that gives the resident clear explanation of what his or her rights are. Think of how this is what we're shooting for, a really resident-centered situation when the facility isn't focused on how can I get the most reimbursement, but instead, what's the best for this person and how am I going to provide care consistent with the nursing home reform law. And part of the philosophy of that is that the nursing facility is home for this person, and as much as possible, he or she should have the right to stay. Make the same point once again, that you don't want what's currently happening now too frequently to continue happening, where people feel obligated to leave one way or another by a facility that styles itself as specializing in rehabilitation care, claims that it doesn't provide custodial care. You shouldn't be, as a nursing facility, bringing people in for their Medicare and then using their Medicare and then pushing them out the door. And in the advocacy community, we want to push back hard against that. I think these notice requirements are real good for that particular issue, and we shouldn't be squeamish about requiring notices in these situations. If the facility is at any point suggesting that the resident should leave the facility, they need to play by the rules and give notice and give people a clear understanding of what their rights are. Two other provisions on transfer discharge to mention here under the new regulations. There is an explicit requirement now that a person cannot be transferred discharged while the appeal is pending, which of course makes perfect sense. And a second provision, which now in the regulation states what used to be in the surveyor's guideline, that there can't be transfer discharge for non-payment if the resident has submitted all necessary paperwork for third-party payment. That is, if someone's in a nursing facility, they've applied for Medicaid coverage, that the facility can't force them out for non-payment at that point because Medicaid is still working on the issue. And so with that, I'm going to turn the conversation over to Robin, who's going to talk about the related issue of the right to return to a facility.
Thank you, Eric. So there are two sort of situations that come up in terms of returning to the facility. And the first is when the resident's return is governed by the bed hold policy. And the second is just when the facility refuses to let the resident return. So I'm going to cover both of these scenarios very briefly. So the first thing I want to look at is just bed hold rights. So bed hold comes into play when a resident goes to the hospital or out on therapeutic leave, which is basically a visit to family or friends. And facilities are required to have a bed hold policy, which says how long they'll hold a person's bed. For residents whose stay is covered by Medicaid, each state will decide if Medicaid will pay to hold the person's bed. And not all states do that, so that really is very state specific. The federal regulations require that the facility has to give residents notice of their bed hold policy at two different times. One is before transfer, and we usually see that done at the time of admission, and then also at the time of transfer. So bed hold is great if the resident only stays for the amount of time that's allowed under the bed hold. But there are situations that arise, such as what if their stay in the hospital or their therapeutic leave exceeds the bed hold period and their bed's no longer being held? What happens then? Or what if the state doesn't pay to hold the beds of residents on Medicaid? Or what if the resident doesn't request a bed hold? Next slide, please. So in these situations, the facility has to permit the resident to return if the resident meets the following criteria. So first of all, he or she must need nursing home care, and he or she must be eligible for Medicare Skilled Nursing Facility Services or Medicaid Nursing Facility Services. Next slide. So those two requirements must be met, and if so, then the resident must be permitted to return to the room they previously had if it's available, or if it's not, they must be given the first available bed in a semi-private room. So I just want to highlight what's new in the revised regs, which is that, first of all, residents now can return to their own room if it's available. That was not the case before. And second, the right to return now applies not just to residents whose stay is covered by Medicaid, as it has been in the past, but now also to those whose stay is covered by Medicare. So those are both really positive changes. Next slide. So we received a number of questions related to bed holds, and they basically fall into two categories. So the first category is this question: what happens if the resident doesn't pay to hold the bed or doesn't sign the bed hold agreement? So in that case, if the resident's stay is paid for by Medicaid or Medicare, and they still need nursing home care, they must be allowed to return to their own bed, if that's available, or the first available bed in the semi-private room. And if the person is private pay, you would argue that if the resident has paid for the entire month of care, they have the right to return to their own bed if it's still within that month of time. So another question that came up is what happens if no bed is available? So in this situation, we would just recommend that advocates and residents need to be really persistent and keep contacting the facility to ask about availability and let the facility know that you're going to be calling and checking on a very regular basis. We tend to see that most nursing homes do have vacancies, and most of the time residents can return. Next slide, please. So the second scenario, second situation related to returning to the facility is the really big issue of what happens when the facility refuses to allow the resident to return. So in the revised regulations, there is some good language that addresses the situation, or at least addresses it partially. So for the first time, the regulations make it crystal clear that if the nursing home won't permit the resident to return, that is a discharge, and the facility must follow the transfer-discharge requirements. So this is a change, and on your screen you can see the regulation language, and I urge you to go back and familiarize yourself with that language. Next slide, please. And just so you're aware that I wanted to show you that there is language that was in the preamble that also talks about the fact that this is a discharge, and I would again urge you to make yourself familiarize yourself with this language, because it's can be helpful in your advocacy. So among other requirements then that are related to a discharge, so what does this mean when we say that in this situation this is considered a discharge? Well, that means that all those discharge requirements kick in. So the facility has to provide a written notice that contains certain required information, such as information about appeal rights and how to contact the ombudsman. The facility has to send a copy of the notice to the ombudsman, and the facility has to allow the resident to return to the facility and then go through the discharge process. And when you think about it, the analogy here is really the eviction of a tenant from an apartment. So let's say the tenant goes to the hospital, and during that time the landlord makes a decision to evict him or her. So the landlord can't just evict the tenant by locking the door while they're temporarily gone and in the hospital. So the tenant has to be allowed to come back to his or her apartment, and then the landlord can proceed with the eviction. So in a similar manner, the facility can't lock out the resident by refusing to take them back. Next slide. But what we see, and the question we got the most frequently related to returning to the facility is this question: what can you do if the facility absolutely refuses to permit the resident to return? So I'm going to say this is a tough situation, and unfortunately we know that residents across the country face this all the time. So I just want to share with you a range of strategies to try. First, the resident can appeal. I believe in some states there's actually an expedited appeal process, so you can get a ruling while the resident is still in the hospital. Unfortunately, that's not the case in most states, but in that situation, you just keep pushing the facility to allow the resident to return, and you can argue that the facility can't discharge the resident pending the results of the appeal hearing. So the resident needs to be and must be back in the facility. So that's one strategy. Another strategy is to contact your state survey agency or your CMS regional office and see if they'll take any action while the resident's still in the hospital. Advocates generally haven't had a lot of luck with this, but I always think that it's worth trying. I'd also recommend filing a complaint with your state survey agency or CMS. Now, this probably won't help the a resident in that particular situation, but in the long term it might have an impact, because if there is, if the complaint is substantiated, and particularly if there's an appropriate enforcement remedy, it can send an important message to other facilities that you can then point to. And that might give you some leverage in persuading a facility to take a resident back. Another strategy is to seek a court order to get the resident back in the facility. And one last approach is to see if you can get the hospital to bring pressure to bear on the facility. I've seen cases where the hospital will actually tell the facility that it won't take any more of their residents unless they allow the resident to return. So sometimes you can have a powerful ally in the hospital. One other question that came up fairly frequently in our previous webinar is, what do you do if the nursing home says they don't have to permit the resident to return because the danger to other residents or staff, or they won't let the resident return because the resident has injured other residents? So in that case, the answer is facilities are not relieved of their obligation to take the resident back, even if they claim danger to other residents or staff. You know, the purpose of sending the resident to an acute care facility is to get them treated. And by the time the resident is ready for discharge, you know, she should be stabilized and no longer be considered a danger. So that is not an exception to this requirement. So that completes our focus on these 4 areas. Before we open things up for questions, Eric is just going to talk very briefly about the health care bill that Congress has been working on and that is now in the Senate. Eric.
Thanks, Robin. Indeed, let's do this quickly. I know it's on the front page of everybody's newspaper. Let's just focus quickly on the nursing facility implications, and that means talking about Medicaid. There are significant cutbacks in this legislation to Medicaid, essentially the elimination of the expansion coverage. That was the care that was added in the Affordable Care Act for people who are less than 65 and who weren't covered by Medicaid previously. But the most important thing for the nursing facility residents is this limitation on Medicaid funding going forward, that it would be tied to a per person cap. And that is an extremely dangerous provision. The caps would be limited. What it meant would be care would be limited by funding. Health insurance generally covers if care is medically necessary. That's the way it works. You've got services that are covered, and if then the person needs the services, they're provided. That's the way that Medicaid has worked. But this legislation would put an artificial cap on Medicare coverage that would not keep up with inflation, particularly from 2005 onwards, because the inflation rate wouldn't be tied to health care. It would just be the ordinary consumer price index, which is significantly lower. And in any case, for reasons that are too technical to discuss here, the cap system is punitive. Even if the inflationary rate was correct, it would still punish states, it would still punish nursing facilities, it would still punish nursing facility residents. Justice and Agent has an issue brief if you want to see the details on that. That's available off our website. Funding for older people is particularly at risk. Medicaid, as most people probably understand, is the big payer for long-term services and supports. That almost 2/3 of residents are covered under Medicaid, and we know this also, that long-term services and supports are expensive. Nursing facilities are expensive, and home and community-based services are expensive. So what you've got is a system that would be squeezing Medicaid financially, and states would be forced to make cuts, and where would they make them? The amount of money that we're talking about is big. The estimate is over 10 years, we're talking about $772 pulled from Medicaid. And I'll reference in passing that the vast majority of that money under this legislation goes to to give tax breaks for the top 1% of Americans. But there's a huge amount of money, and where's the state Medicaid program going to take that from? They're probably going to take it from older people to a significant extent, because there's a lot of money there, and most Medicaid funding for older adults is optional. It's either the optional services. This is optional under federal Medicaid law. Home and community-based services generally are optional, so that could be cut. And perhaps surprisingly, most nursing facility residents are in an optional coverage group, that if they were eligible for SSI, they would be a mandatory coverage group. But they're not, because when you're in a nursing facility, the SSI threshold is $50, $60. Anybody with income more than that is eligible through a different mechanism, which is, under Medicaid law, an optional group. So I'm sure folks looking at online yesterday or your newspaper this morning see that the Senate has delayed their vote. Does that mean that we could just kick back and say, okay, not worry about that anymore? The answer to that is no, absolutely not. That this continues to be an incredibly important issue. And folks may remember that the House of Representatives also pulled similar legislation in the tail end of March, and then it was back at the beginning of May and rushed through the House, and it passed. So people should not declare victory at all. This is going to be a continuing legislative battle. It is likely that the proponents of this legislation are going to reemerge a week or two or three from now and say, oh, we fixed it. We've added some more money for opioids or health savings accounts or something else. Everything's fine now, and there'll be pressure on maybe some of the holdout senators to declare victory and move on. Is that okay? No. This bill it can't be fixed. It's a pig. You can put lipstick on it or nice shoes or a top hat or whatever you like. It's still not good. And that's the fundamental problem with this bill. It's not, I would suggest that it's not, and other people have said this obviously, it's not really a considered effort to make the healthcare system better. It's not designed to improve healthcare. It's designed to pay less for healthcare and to return that money to folks who've of the very, again, the highest tax brackets. So we would suggest that people call your senators. Here's the switchboard number. I'd mentioned that it only takes 5 minutes or so, and I'm going to leave this up when we go to questions. Just think about it. We're really talking about 5 minutes after this webinar is over. Make the call and tell your senator's office that you're opposed to this legislation. So with that, let's switch to answering some of the questions that have come up during this webinar.
Thanks, Eric. And I do realize that we're close to the end. The webinar was scheduled to end at 3, but for those of you who are able to hang in with us a little bit longer, we will continue for at least 10 more minutes. So let's look at having at least 10 minutes of questions. And thank all of you who are able to stay with us. So you can submit questions in your question box that's located on the control panel on the right-hand side of your screen. I want to introduce Alicia Lineswala, who is our Public Policy and Program Specialist at Consumer Voice, who's been playing a really important role behind the scenes and is helping us with asking your questions. So Alicia, you want to get us going with the first question?
Sure, Robin. So the first question is a rehabilitation question. It was mentioned that you should push therapy to the facility. Can you give us examples of how we can do that?
Alicia, I missed the second part of what you said. Could give us examples of what? Of what? How to do that?
Push therapy to the facility. Yes.
Okay. Well, that was one of the questions that we had, and I, in the interest of time, had not gotten to that. I think this is actually, it's difficult. but there are things that people can do. I think what we know is that there needs to be a physician order for therapy, although the revised requirements do allow the physician to delegate authority to the therapist. But what you really need to do is try to persuade whoever is making the decision that the particular resident needs therapy. So one strategy is to get the resident's primary care physician or other physician who's been involved in the resident's care to intervene, the surgeon, whatever doctor who can intervene. Possibly ask for a new assessment. Use the care planning process. Talk about what the resident needs in order to be discharged and able to go home. If the resident needs to be able to do certain transfers, like from the bed to the wheelchair or a walker, in order to be able to go home, then it's not good enough to say, well, the resident's plateaued and that's the end of it. You say, this is what the person needs to leave, and maybe that will work. But it's a matter of persuasion. I think the last time we had some examples of physician letters, one that was successful, one that wasn't successful, but it was very good, and one that was a template that an attorney wrote based on those letters, trying to amass the evidence that would persuade the decision maker at the facility that, yes, we should provide more therapy. Also give them Jimmo, give them everything you can, but it's a matter of persuasion, and that's why it's difficult. You can't really file an appeal. There's nothing to appeal formally.
Thanks, Toby. So our next question is a visitation question. If a guardianship order specifically states which family members are able to visit and sets guidelines for the visits, can the resident request to see other relatives, and will that request be honored?
Thanks, Alicia. So I think I would want to know why a guardianship order has that information in it, and but I think that if a resident is asking to see other relatives, then steps should be taken to try and honor that. And so if that means going back to the court and trying to get the guardianship order amended so that the resident could visit with those relatives, then I think that that's an appropriate step that would need to be taken. It might mean that there would need to be special accommodations made, or maybe supervised visits, depending on what the situation is, but I think all of that needs to be brought to light and taken into account, and trying advocates, whether they be ombudsmen or working with attorneys or legal services folks or the guardianship representatives, can be working together to try and assure that residents get to see the individuals that they would like to visit with.
Great, thanks. So the next question is a transfer-discharge question. Nursing facilities are giving notices that the coverage is no longer being paid by Medicare, and then telling the resident they must leave, but refuse to issue involuntary discharge notices because the resident was on short-term only. Can you speak to whether the short-term admission would allow an exception to the involuntary discharge notice?
No. That's the very simple answer, that these kind of exceptions are not consistent with the regulation, period.
Great, thanks.
This is Toby. I agree with her completely that these are two separate issues. Whether Medicare pays is one question. I think he set that out very clearly in the PowerPoint presentation. But whether the resident has the right to stay is a different question. There's not a non-payment situation because the facility has decided Medicare won't pay. These are two separate sets of laws, two separate notices that the residents are entitled to get, and they can't just drag themselves onto your discharge because we think Medicare won't pay anymore.
Thank you both. So the next question is a return to facility question. How can you find out if a nursing facility has an open bed? Is there a way to find this out without having to rely solely on the nursing facility representation?
So this is Robin. I'm not aware of any way that you can find that information out, easily at least. You know, it might possibly be information that you know, maybe an area agency has if they're tracking available beds in their area, but I'm not aware of any way to do it other than calling the facility, or perhaps maybe asking the hospital. But I would like to see if my illustrious colleagues have anything to add to that.
This is Eric. I think you could call the nursing facility and just say, put yourself forward as someone who's interested in finding a spot, or talking to people. If you've been living in the nursing facility, presumably you know somebody there, or if you left the nursing facility, you might know something about what's going on in the nursing facility lately. But I think the main point for me is that this is consistent with what you said, Robin, is just be really persistent. That the facility may, for a day or two, make things up about we're being full, but my experience is if they understand you're not going away, they'll understand that that's a strategy that's not going to work for them.
Yeah, I agree. That advocates should do what they do so well, which is being tenacious. So back to you, Alicia.
We know the occupancy rates are in the 80s. So it's unlikely that a facility has no semi-private rooms. It just seems so unlikely. But I agree with what you're saying. There's no way, no place this is posted. That's the problem.
Right.
Yeah.
Okay, great. Our next question is a visitation question. Can facilities limit hours of visitation when visitors present behavioral issues?
So according to the regulations, the resident can choose when they want to see their visitors. And so there might be that special accommodations might need to be made in order to assure that the visitor is not infringing upon the rights of other residents during that time. So it might be that the visit needs to take place in not in the resident's room, but in a separate area that they could have some privacy to visit. But the regulations are pretty clear that restrictions are not to be placed on timing of visitation.
Okay, great, thanks. Our next question is a transfer-discharge question. What might these transfer-discharge notices look like? We are getting such a variety. Is there any movement to formalize a notice from the meetings from CMS guidelines?
So, I'm sorry, is there a movement towards some sort of template or form? Is that the question?
Yeah.
So yeah. I'm not aware of that. In some states, there's certainly some sample documents like that. I'm not aware of any particular CMS formatting that's in the works.
So this is Robin. I definitely agree with what Eric said. I mean, we're not aware of anything that CMS is doing, but I do know there certainly are, as Eric said, some states that have a required form that's standardized, and certainly getting your hands on what other states have and then doing some state advocacy is a way that you can move toward having a standardized form, at least in your state.
Okay, thank you. And I think in the interest of time, we'll just take one last question, and it's a return to facility question. What kind of court order would need to be filed to get the resident back in the facility? Would this be in federal or state court? And anyone
So
yeah,
please. I'm going to have to defer to my colleagues because I don't know the answer to that one. So
this is Eric. When I did direct service, I certainly did some of these, and they were in state court. And if somebody wants some sample documents, just send me a note, and I note that everybody's email address is up on the screen right now.
Okay, thank you. And I'll pass it back to Robin now.
Okay. Thank you. So just a few reminders in closing. We will post the webinar recording and PowerPoint slides on the Consumer Voice website, and particularly on our nursing home regulations webpage. And we'll send you a link to that in a follow-up email. And just a reminder also that we've written issue briefs on these topics, and you can find them again on our website. Also, as Eric noted, our contact information is on the screen, so if you have questions or if we can help in any way, please just contact us. So a big thank you to all the speakers, a big thank you to all of you for taking the time, and particularly the extra time today, because I know we went just a little late. But thank you for joining us today, and just one last plea, please, please, please take a few minutes to make a call to your senators to help save Medicaid. It is probably one of the most important actions you can take to protect nursing home residents. So thank you, and we hope you have a good rest of the day.